Afternoon, everybody. We want to welcome all of our guests to our Zoom lecture meeting today on behalf of the Women's Fund. Welcome to our latest Doc Talk hybrid lunch and learn. We have an insight-packed agenda for today, and we're really excited that each of you are here with us today, spending your lunch hour with us. The mission of the Women's Fund is to provide Houston area women and girls with the tools they need to be advocates for their own health. Our health education classes are unique because they are really including preventative curriculum-based classes that teach resiliency skills and relate those skills to current health risks. So as you're tuning in today, we're going to invite you to keep your minds open. We're going to be talking about hormones and menopause. Often these topics get talked about either casually or something that does not get brought up at all. We're wanting to break those traditions and bring forward the importance of being in tune with our bodies and really embracing all that it means, all that it feels like to be a woman. So at the end of the day, we are the experts for our own bodies and our hormones, and we want to help you become that expert today. Bringing awareness to this topic and focusing on hormonal health can be life-changing. Typically, we talk about menopause and hormones in the most confined spaces, like our doctor's office. We may talk about this with our girlfriends, our female family members, but these subjects are just as important as any other reproductive health topic. After today's discussion, we can learn tools to empower ourselves and the women around us. We hope that you can find some answers and motivation to talk about menopause and hormones confidently. We will proceed with the conversation in just a moment. As a reminder, we're going to hold 10 to 15 minutes at the end of the program for question and answer period. The Women's Fund is also recording this, so we're going to share it today on our website, on the Women's Fund website, and also on YouTube in the next week as well. So please share this if you think it's helpful with your friends, your family members as well. Before we get started, a couple of meeting rules. I'm sure we're all used to this by now, but if you're not already muted, please mute yourself. And if you've got any questions throughout the presentation, you can hold them or you can put them in the chat box. We're happy to take them there. You can do that now. You can save them to the end, whatever kind of feels right to you. And in order to give our speakers the full stage and full attention, we're going to make sure that their presentation is our focus, and we'll kind of do those questions towards the end. Very excited for our experts today. We have OBGYN and Medical Director of NULA Health, Dr. Mayor Mbe. Dr. Mayor Mbe is a highly rated OBGYN in New York City and the Medical Director of NULA. Before joining NULA, Dr. Mbe worked in private practice, caring for pregnant and non-pregnant people. She also boasts several years of experience as a medical advisor, digital health startup consultant, and content creator for startups such as Natalist and Frame. She's on a mission to bring empathetic, holistic, and affirming reproductive health care to everyone, with a particular focus on marginalized groups, including people of color and the LGBTQIA+ community. I can't think of a better expert to be with us today. So we're going to get ready to dive into all things related to our hormones and menopause today. And remember, the whole goal here is for you to walk away with more answers than questions. So let's jump right into it. Dr. Mbe, I really want to talk a little bit about what are the barriers to getting people to talk about hormones, reproductive health, and especially menopause. What's keeping people from doing that?
Yeah. So there's a lot of things. There's definitely a very layered stigma around menopause. So I think kind of the first hurdle is the fact that in kind of a more patriarchal system, we do see that, women's issues and female health tends to be kind of shunted to the side and kind of put under the rug. And it makes people uncomfortable just to talk about it. And menopause, especially because it's something that's seen or portrayed, I should say, as being kind of a sense of loss or an ending of a phase of life. And especially in movies, media, I feel like we see a lot of menopausal people being shown as kind of crazy or too moody or, like just so much up and down going on. So I think it makes people very uncomfortable to think about that. I think there's the general stigma of aging, just especially with women in particular. Aging is something that the beauty industry just kind of makes us want to try to stop and avoid, as opposed to kind of embracing it and kind of going with that flow and allowing your natural aging to happen as it should. And so on top of that, we have the mental health aspect. So with menopause, especially, it's like puberty. There's a lot of hormone shifts. There's a lot of things going on that are going to affect your mood. And so mental health issues that kind of come with menopause are overlooked because we, again, don't talk about those physical, mental, emotional changes that are to be expected. So I think it's important to have talks like this because it's important to reframe the mindset around this, because menopause should not be seen as something that is bad. It's just a phase of life, just like anything else. And so I like to try to use a language of empowerment around this because there's still plenty of life after menopause. So it's important that we kind of talk about it, prepare ourselves for it. And then once we actually reach menopause, we kind of know what to expect. So there's not that sense of what is happening to me right now.
Yeah, I feel like that's kind of one of the biggest issues is that people really do not understand what is happening to them.
Yeah, exactly.
And often can't get straight answers.
Mm-hmm, mm-hmm.
So I mean, I know we're going to talk about a lot of these things, but
Yeah.
not everybody's here on this call with us. And we're going to all walk out of here and speak to other people about this topic, I hope. Where can we direct people for really good information? Because I know just Googling stuff is not the right answer.
Yes. So Google is definitely not where I would go, though you can find obviously communities of women going through menopause. So for example, even within NULA's community, we have a lot of people who kind of find each other in terms of having certain symptoms, and kind of posting a question like, oh, I'm going through this. Is somebody else having an experience with that or have had an experience with that? Talking to your provider is, of course, kind of the first thing. That might not be the easiest for everybody, especially setting up an appointment, going to that appointment. People have busy lives and maybe don't necessarily want to fit that in. But I think just kind of talking to your provider before you get to menopause is always helpful, just to kind of get a sense of what can I expect? What should I be looking out for? What are the red flags I should be worried about? And another person to look to is actually your parent, like your mother or an older sibling, because a lot of times menopause symptoms run in families. So a lot of times the menopause symptoms your mother had or your older sibling had is going to be very similar to what you might have. So it's kind of nice to have a very close relation who's able to tell you, okay, this is what I went through, so here's what you might be able to expect.
Yeah. I know one of the things you said a minute ago is how this is a phase of life.
Mm-hmm.
Does that mean that we have to just kind of accept what's happening to us?
Yeah. So this is a topic I go into a lot with the patients that I see. Menopause symptoms are something that don't have to be treated. So I always tell people, first and foremost, it's all about how you are feeling. So because the symptoms of menopause can range so much from person to person, there's not, and it's not necessary to fix anything. But if there are symptoms that are bothersome to people, so for example, everyone hears about hot flashes. If those are happening to a degree that is really bothersome to you, then that's when we start talking about, okay, how can we make you feel better? How can we help this disrupt your life less?
What other kinds of symptoms? Because for many people, this may be the first time they're hearing about anything other than hot flashes. I mean, I think everybody knows about hot flashes,
Right.
but there are other things that go along with entering menopause
Mm-hmm.
or being in
Yeah.
menopause.
So there's kind of 4 cardinal symptoms that we expect in menopause for most people. Hot flashes is one of them. Poor sleep is another one. So a lot of times people think they're having sleep issues for other reasons, but it might be related to the hormone shifts with menopause. Poor mood, or at least mood changes. And again, that's usually due to those hormone shifts. And then vaginal dryness is pretty common as well. All of these are things that can be treated if they're bothersome enough to the person experiencing them. Not everyone's going to have all those symptoms. Not everyone's going to have the same mix of those symptoms. And so it really requires a personal touch to kind of figure out how are we going to best treat your symptoms.
So before we talk about how to treat all those symptoms, you mentioned like everyone doesn't get these symptoms, and
Mm-hmm.
menopause doesn't happen for everyone in the same way.
Right.
It doesn't happen. It's not like you wake up one day and you're like, oh, I'm in menopause. Can you talk a little bit about kind of that transition that really
Yeah.
happens for people? Because it doesn't just start when someone hits 45 or 50. This goes all the way back, right?
Yep, exactly. So I do have a little slide here. Let me
Oh,
pull it up
look at me
here.
just toss into a slide. I love this.
It's a little bit busy, but we'll go through it.
You're going to get us through it. I know it.
Let me make sure. Oh, of course it's not working now.
There we go.
Okay.
We're there.
All right.
Oh, yes. This is kind of my vision. Okay, great. This is awesome.
So in terms of kind of what's going on in this graph, so the purple and the yellow lines are your estrogen and progesterone levels. And then the dashed line is your FSH, which is follicle stimulating hormone. So during menopause, what we see is that the estrogen and progesterone will go down as your FSH goes up. And typically your estrogen going down is what's causing all of these symptoms during menopause. So I always compare it to puberty, where because of the kind of longitudinal shift of these hormones, it is going to be a process. So most people think of menopause as kind of like a specific time, when it is really kind of a long process. It does take several years. So as your estrogen goes down, it's not going down as smoothly as this graph is showing. In reality, what's going on is there are spikes, and the spikes and the dips are kind of what's causing those episodes of symptoms. So usually earlier on in the process, we're not seeing that as much. And most people will actually start the perimenopause phase, which is that phase before you've reached 12 months of not having a period. So that phase is where you'll have irregular periods. You might have started having symptoms like the hot flashes or poor sleep. And that's usually any time after age 40. On average, usually after age 45, but sometimes a little bit earlier. And then the actual average age for menopause, where symptoms end or periods end, is age 51. And so again, if you talk to your mother or an older sibling and their age is, higher or lower than that, you might have menopause around that age as well. So I always go through kind of there's three main phases. You have perimenopause, which is, as I said, around or near menopause. So you start having those symptoms. Menopause is actually having had no periods for 12 months. And then you're postmenopausal once you've gone past that 1 year. And that's the phase that you kind of remain in until you're older. And postmenopause, to get there, usually does take about 4 years. That's the average time. And during that time, a lot of times people are having these symptoms. And so that's when we typically will start treatment for certain things, and especially if it's really affecting people's quality of life.
Wow. So, I mean, I look at this graph and chart, and really, especially the estrogen drop, I mean, we go back to, like, for some people, mid 30s. And I don't think most of us think about that happening at the same time that a lot of people are still having children.
Right. Yeah. And the decrease is very slow kind of early on in that process. And then once we get to the 40s, that's typically when it starts to speed up. And so a lot of people will come in with complaints of, my periods are suddenly very different.
Yeah.
And usually it's because we've kind of started that slow decline in estrogen. It doesn't mean you can't get pregnant. It doesn't mean you don't still have ovarian function and everything, but it does mean we're kind of starting that slow process.
Interesting. And so you mentioned that if you kind of talk to your older siblings, your mom, your grandma, like, you might get some ideas about how this might look for you. Are there other things that impact what menopause is like for you? I mean, I think about some of the things that might come to mind for people, and I don't know if they're causal or not, but does it matter if you had a child? Does it matter if you were on birth control? Do any of these kinds of things impact, or do we even know the answer, what menopause is going to look like for you?
Yeah, so birth control definitely does affect it to a certain degree. We actually use birth control as one of the ways to manage symptoms, as a low dose option. So it typically does tend to help symptoms for most people. And then having had children or not having had children does seem to also affect it a little bit. People who have not had children tend to have more symptoms when they get to menopause, which they think is related to kind of the overall number of ovulations you've had in your life. And then in terms of other things that might affect it, Most of the time, the number one thing that's going to help is actually exercise, which is something that people don't necessarily kind of tie to it. But exercise has actually been shown to decrease the symptoms that people have, and to improve the overall experience of menopause. And it also decreases your risk of things like depression, osteoporosis, and some of these other issues that we see happening after menopause. So that's usually my number one recommendation for everybody, because that's an easy thing to do, even if it's just walking around the neighborhood or just getting a little bit of exercise in at home. But just moving the body consistently a couple of times a week will actually help people a lot.
Yeah. So we've kind of jumped into talking about some of the things that we can do as women once we kind of get to that point to mitigate some of the symptoms, get us some relief from those things. Can we talk a little bit about, whether or not, how do we know if things are bad enough to where we need to be thinking about making some changes? Clearly exercising, we should be doing that anyway. But how do we know when things are bad enough, or is it dependent on the person?
It honestly is dependent on the person. So menopause, nothing that happens during menopause is life-threatening or anything like that. So again, nobody needs to be on medication, but it can really disrupt people's daily life, and especially the quality of life that you're having. And it can impact relationships too. If you're going through all of these issues in terms of not sleeping well, not your mood is all over the place, and you're having vaginal dryness or what have you, that can definitely affect how you're interacting in your other relationships. So typically the most common reason people will come in to be treated is things like hot flashes or vaginal dryness. That tends to be the most common thing. And we can usually tailor treatment to be based on what symptoms you're having and what symptoms you specifically want us to be treating.
So I know we've touched a little bit on some of the treatments, and we mentioned exercise. You talked a little bit about birth control pills, because obviously those are hormones. So
Yep.
supplementing that. What else is on the table now?
Yeah.
Because I think when you talk to a lot of folks, they say, well, we shouldn't do anything at all. It's not healthy for me. It's dangerous. But I feel like treatments have come a long way, from maybe what they were 20 years ago.
Yeah, so we now have a lot of options actually, in terms of hormonal and non-hormonal options. A lot of people prefer to avoid hormones, and that's totally fine. One of the most common things we will do is actually using either certain supplements or antidepressants. There are a lot of antidepressants that actually work very, very well for the menopause symptoms that people have. And we do them at low doses. So they're not necessarily being used as antidepressants, but they are very effective for hot flashes, for sleep issues, especially insomnia or not being able to sleep at night, and for the mood changes that we see during menopause. Those are probably the two that I use the most in terms of treating for people who don't want to use hormones or can't use hormones. And then we also have hormonal methods. So birth control pills are usually our most common option because they're low dose, they're typically very low risk, and most people tolerate them very well. And then we have actual hormone replacement therapy, which is a little bit higher dose, but still low dose. And I think that's usually what has the biggest misconceptions around it, because of the concern of, okay, well, I shouldn't be taking these hormones. That's not safe for me. But if you think about it, you've been kind of swimming in estrogen your whole life. So the hormones themselves are not safe. Typically, it's the way that they're prescribed that has to be watched. So we typically will prescribe estrogen and progesterone because estrogen all by itself can actually increase your risk for uterine cancer if you have a uterus still. So we have to do it with progesterone. So it has to be kind of a dual therapy. And we typically try to do the lowest dose possible for the shortest amount of time possible. So we will start it, say, when someone starts having symptoms at age 49, and then continue that through maybe a few years until we've passed actual menopause, and then we start to taper it back down. So my goal usually as a provider is we want to be using this for less than 10 years. That's what the research has shown us is safe. And we want to make sure that we're using the lowest effective dose for your symptoms.
So I'd love to back up just a second. I want to dive into the whole hormone thing, hormone replacement therapy, but you mentioned supplements. Are there supplements that people can take that would be effective and helpful with your symptoms? Or is this something that really needs to be part of a visit with your physician to make sure it's part of your overall care?
Yeah. So there are some supplements that have been shown to be effective for mild menopausal symptoms. There's nothing that's quite as effective as the prescription medications that we usually prescribe. But we do have to kind of tailor that based on what other medications are you on? What other medical issues do you have? Is this safe for you to be taking while we're taking care of those things as well? So a lot of times it does require a discussion with your provider because it needs to be unique to your situation and what is safe for you.
So I know we're going to talk a little bit more about hormone replacement therapy, and especially this combination of using estrogen and progesterone and how that all kind of balances out. One of the things that I've been seeing, and I don't know if it's because I knew I was going to be moderating this talk or I'm just starting to see it, but I've seen a lot of things, ads pop up, whether it's on social media or someplace else, about getting your hormone replacement therapy remote.
Mhm.
So it's not a doctor that you visit and see. It's not someone who treats you for something else, but that it's online in a way. And you
Yeah.
talk to someone online, they prescribe these things for you, and off you go.
Yeah.
And it appears there's no blood test to check anything. There's no levels being checked or anything like that. What are your
Mhm.
thoughts on, generally speaking, that kind of process for something like this?
Yeah, so I think it's great. I think it makes it more accessible for people. And especially because this is a topic that some people are uncomfortable talking about and still, struggle to kind of bring it up. I think it makes it nice to be able to speak to a provider from the comfort of your home about your symptoms and about what's going on, and to have an effective treatment prescribed to you. Most of the people we see, most of the people we see tend to be kind of what we consider low risk menopausal patients. And so as long as you kind of fall into that category, it is totally safe to be getting that prescription remotely. If you have any kind of high risk concerns, so like say you have a history of breast cancer or anything else like that, then I probably wouldn't recommend that. Then we probably do need to see you in person and kind of discuss some things, potentially do any kind of ultrasounds. Because the one thing we always want to make sure of is we're watching that uterine lining, because that's where that estrogen level comes in. But for low risk people, you don't actually need to get blood tests. The blood tests are actually have been found to be very inconsistent, because as I mentioned before, your estrogen is kind of peaking and troughing multiple times throughout the perimenopausal phase. So if we happen to catch you during a time where it's back at a normal level, then it doesn't really prove anything. It just happened to be normal during that day. And so we usually don't actually use lab testing to necessarily confirm menopause unless it's really uncertain. We actually use symptoms as a way to kind of diagnose it.
That's really interesting. And the way you're talking about it, it's almost like I feel how we've been talking about mental health in the last
Mhm.
3, 4, 5 years,
Yeah.
about really making it accessible, the help that people need. And digital's become such a big part of that. I'm excited to hear that this could also move into other spaces where maybe people aren't quite as comfortable talking about just kind of openly with everyone.
Yeah, absolutely. I think it's important for getting people to get the treatment they need, because I do think a lot of people, if you don't ask, aren't necessarily going to volunteer that information. So as providers, we have to make it easier for people to get the information that is accurate that they need, and then to give them their options so that they can make an informed decision about what works best for them.
Yeah. So you mentioned, doing a blood work is not necessarily the best way. It sounds like it could be, it could be helpful, maybe not so helpful in trying to figure out what your dosing should be. Because you mentioned doing, the lowest effective dose that we can when it comes to hormones. So how do you figure that out? How do you figure out what dose someone needs if we're not taking, if there's no real accurate blood test to kind of figure that out?
Yeah. So kind of standard of practice is we will start with the lowest dose of estrogen. So typically I myself prefer the estrogen patch, just because, it's easy not to have to take a pill. You only have to switch it out a couple times a week. And so I usually will start with the lowest dose estrogen patch, and then the lowest dose of progesterone that matches that.
Okay.
With people who have very severe symptoms, sometimes I'll bump it up to that next level. But usually what we'll do to track whether or not we need to increase the dose is just track symptoms. So if within most of the time, your symptoms will improve within about 6 to 8 weeks of starting a regimen. And so if your symptoms are not better within that time frame, then I have people come back in, or we have a virtual call and we'll go ahead and increase to the next dose. And then we just do that incrementally until we get to a level where the patient is satisfied. And at that point, we'll just kind of stay at that level until we've gone through a couple of years, and then we can start to kind of taper it down and see how you do. So usually it's just kind of a stepwise increase until we reach the level that works for that person.
That's so interesting. So 6 to 8 weeks to figure out if it's kind of working. Is that a challenge for you as a physician? Do you feel like people want to be fixed like yesterday when by the time they've come and talked to you?
Most of the time people are very understanding, I will say,
Okay.
but I do think most of the time you want something that's going to work quickly.
Yeah.
And unfortunately, with most of these medications, it does take a little bit of time for those hormones to level out.
Yeah.
Usually people will at least start to notice improvement within about 2 to 4 weeks. So at least you'll kind of see, okay, there's light at the end of the tunnel before we get to that 6 or 8 weeks.
Got it. And do you find that the estrogen and the progesterone are tackling kind of all of those big symptoms you mentioned? You know, it's not just tackling the hot flashes, but it's tackling the mood, it's tackling the sleep disturbances. Is it doing all of that, or do you find you need to supplement with kind of, this is where maybe the supplements come in?
Yeah, usually hormone replacement therapy is the most comprehensive in terms of what it treats. So because we're kind of fixing the underlying issue of the hormone shifts, a lot of those symptoms do go away with hormone replacement therapy. With the other medications, a lot of times those tend to be specific to specific symptoms. So for example, with the antidepressants, there are certain ones that work really well for hot flashes, but don't necessarily help some of the other symptoms. There are some that work really well for mood and some that work really well for sleep. So a lot of times if someone's having all of those symptoms, I will usually recommend hormone replacement therapy, versus if they really specifically have an issue with their hot flashes, I might say, okay, you might not need hormone replacement therapy. We could probably treat this with just one of these other medications that's not hormonal.
Yeah. And you mentioned that, you know, of course, there could be, if you, especially if you were just doing estrogen alone, and a higher risk perhaps of cancer. And are
Mhm.
we talking breast cancer and uterine cancer?
Mhm.
Is that really what we're
Yeah.
focusing in on?
Yes, so specifically breast and uterine cancer. And for someone who's had a hysterectomy, has had their uterus removed, there's no concern for that
Oh,
necessarily. And so a lot of times for those patients, we can just do the estrogen. But if there is a uterus there, then we typically need to do the progesterone, because that's what your body naturally does. So your estrogen is what grows the lining of the uterus so that you have a period. And then your progesterone is kind of what stabilizes that so that you're not just continuously growing that lining. And so
yeah.
we just kind of mimic that in the hormone replacement.
And that just kind of keeps our body kind of back where it was before.
Exactly.
Now, you mentioned it grows the lining. We're not going to have periods again, are we?
No, no.
Okay.
So typically,
I mean, that just
typically
seems
the most,
cruel. I mean, if
I
that's
know,
what's going to
right?
happen, that doesn't seem right.
Most of the time, people will have a little bit of irregular spotting in those first few months on the hormone replacement, but then that usually will stop.
Yeah, because I'm thinking, wow, that would not be joyful.
Yeah, no,
Um,
but
and you
most people
mentioned
would be
kind of the
mad.
safe period. You know, clearly some research been done on all of these sorts of things.
Mhm.
10 years kind of seems the right amount of time. After that 10 years, do people go back to having symptoms again and it's just not safe to use the hormones anymore?
So the research that's been done has just shown that if we use it for too late after when menopause started, then there's a higher risk of it affecting kind of heart disease risk and things like that. And so for that reason, we typically want to limit it to within 10 years of when menopause began, and typically under the age of 60. And most of the time, that's when people have their most severe symptoms. Once you've gone through full menopause, you're postmenopausal, those symptoms have stopped, and we usually
Oh,
don't
okay.
need the hormones anymore. So it's not something you have to deal with forever. It's definitely just a phase.
Just a phase,
Yes.
just a phase. One of the things that we didn't talk about as kind of a major symptom, but something I hear a lot from my friends is the weight gain part.
Mhm.
Is that part of menopause? Is that just part of getting old? Like where does that fit into that whole world? And does doing some of these treatments for the other symptoms help with that?
Yeah. So the weight gain we typically see around this time is a mix of reasons. It is partially menopause, just because, again, of those hormone shifts. And then also partially just aging because our metabolism starts to slow down at a higher rate once we get around that age. And so with both of those things kind of affecting it, a lot of people will see that it's harder to lose weight. So a lot of people will be like, I haven't changed anything about my life. I'm eating just like I used to. I'm working out like I used to, but I'm not losing any weight, or I'm kind of gaining a little bit of weight. And usually for that, the hormone replacement therapy does tend to help because it levels out hormones enough that we don't see as low of a metabolism. Like we kind of keep our metabolism a little bit more steady. Aging still is going to affect that. So a lot of times I will warn people, it's not a magic pill that's going to fix it, within a day or two. But over time, as long as we're eating healthy and we're still doing exercise and kind of moving your body, the three things together can actually help to improve metabolism and improve weight issues.
And I can imagine too, if you have mood issues, you're not feeling your best, you're also not sleeping. If you can tackle those things too, I imagine that also makes the exercise easier, eating right easier. I can imagine that helps with everything.
Yep, exactly. It's definitely something that's great in terms of overall quality of life, overall health and everything. So that's why it's one of my favorite ways to treat this, just because it does tend to blanket all of the things people are dealing with during this time.
So how did we get to the place where many people have the impression, and I feel like even many doctors have the impression that doing hormone replacement therapy is not a good idea, that it's not safe for people? How did we get there?
Yeah. So there was a study, and I can't remember the exact year, but the Women's Health Initiative study that was done several years back. And that's essentially what kind of kickstarted this distrust of hormone replacement therapy, because that study looked at patients who were aged up into the 60s and 70s who were on hormone replacement. And it found that there were higher rates of cardiovascular disease and other issues. And so based on that study, people started to say, oh, okay, well, this just isn't safe for anybody. And what is actually true is that those people are not the best candidates for it. So we don't want somebody who's in their 60s or 70s to be starting hormone replacement at that point, because it's too late then. So that's why we have those limits now where we say, okay, if we're starting this hormone replacement, you need to have been within 10 years of having started menopause, and you need to be under the age of 60, because those are going to be the best candidates for it. And then we typically try to stop it as soon as possible. Once we've kind of gone through that phase, periods have stopped, we'll start to taper down, and hopefully you won't be needing those medications anymore.
Wow. That makes so much sense. But I'm sure you hear all the time from people that, they say, hey, I don't think this is safe. I do feel like that is a big barrier for people.
Yep. It is something we have to kind of educate people about. And especially because the study itself was accurate in what it said. And it just proved that, yes, we have to be very selective in who we are giving this to. But I think as long as it's used productively and it's used effectively, those risks are mitigated. And so usually we will make sure that when we're seeing somebody, we're kind of checking off those boxes, and then we're making sure to follow up throughout the time that you're on that medication until it's time to stop it. Most patients are very happy once they're on their hormone replacement, just because, as you can imagine, sleeping better, having a better mood, and avoiding all of these other symptoms like the hot flashes and vaginal dryness does tend to improve just general quality of life. And then once we get through everything, you're now medication free, past this phase, and you can kind of enjoy life again as you did before. So our goal is just to get people through this phase, get them through it healthy and happy, and try to avoid these kind of significant symptoms that we see.
Yeah. Dr. Mpe, will you quit sharing your screen just
Oh
so
yeah,
we
yeah.
can
Sorry.
we can see your loveliness?
Yep.
It'll also help me see our questions as they're coming in as well. I would love to take a few questions. So we've got a few folks kind of talking about menopause and getting pregnant.
Mhm.
Can you talk about your ability to have children kind of once
Yeah.
we have gotten into menopause?
Yeah. So during the perimenopause phase, kind of when periods are irregular, and patients are sometimes having these symptoms, you definitely can still get pregnant, because at the end of the day, your ovaries still have eggs in them. Your ovaries are still producing an egg every once in a while. That's why those periods are irregular. It's just doing it inconsistently. And so we do see people who come in with a surprise pregnancy because they thought, oh, well, I'm going through menopause. It's been, 6 months since I've had my period. And then all of a sudden they're pregnant. So a lot of times that's one of the reasons that we will actually do birth control pills, because it both prevents pregnancy if you're not trying to get pregnant, and it provides some level of stable hormones for you during this phase. So I always warn people, I'm like, just because we're in this phase, it doesn't mean you're let through and through done with pregnancy. It could happen. So we definitely do see it, and have to kind of warn people about it.
Yeah, that kind of goes to that point that you said about how this isn't just like some cliff you drop off. It really is this gradual process. So it's not like just one day, you
Yep,
went from being completely everything's level with your hormones and the next day there's nothing there.
exactly.
You really have these peaks and valleys.
Hmm.
One of our other questions, somebody wanted to know if there's a way to delay menopause. Are there things,
Hmm.
they mentioned things like acupuncture,
Hmm.
herbs, supplements. Are there
Hmm.
things that we can do from that way to hold it
Yeah.
off?
Yeah. There's no way to really delay it, because it's based on a couple factors, but it's typically based on how many eggs you were born with. And so what happens is once we get to the end of the eggs in the ovaries, that's when menopause starts to happen. And so it's typically kind of absolute in terms of that, but we can delay or at least improve symptoms with things like acupuncture, and certain herbs as well as herbal supplements. So there are ways for it to improve the symptoms that you're having, or at least prevent you from having those symptoms. But unfortunately, there's no way for us to totally delay the actual start of menopause.
Yeah, and kind of to your point earlier when we started, this isn't it's not like a bad thing. It's just a thing.
Hmm.
This is
Yeah,
a phase that we are going to go through, and there's nothing harmful to us about
exactly.
it. It's harmful how we feel, perhaps.
Right.
The hot flashes, the not being able to sleep,
Hmm.
certainly the mental health issues there as
Yep.
well. Can we talk a little more about the mental health piece? Because one of the questions somebody asked was about, I know you talked about there are certain antidepressants that work for some of the symptoms,
Hmm.
and then there's also this whole other mental health piece. Could we talk a little more about antidepressants, a little more in detail about the antidepressants
Yeah.
themselves used to relieve some of the other symptoms, but then also that mental health piece and what part that kind of
Yeah.
plays in the
Yeah.
process?
Yeah, so the antidepressants are great in terms of some of the specific symptoms, and we do a lot of times use them both to work as an antidepressant if somebody is having mood symptoms and to treat these other symptoms. Mental health is something that definitely overlaps often with big reproductive transitions in people's lives, because those are times when there's just a lot of change happening. You've got hormones that are fluctuating, you've got symptoms going on, there's physical, mental, emotional change all happening at once. So it makes sense that mentally you're going to kind of suffer a little bit through that. And if you can think back to puberty, I feel like nobody really went through puberty and was like, oh, I felt great the whole time. So it's just a similar thing here. And so I always tell people, never feel like there's something wrong with you or there's any issue. It's just something we have to manage. So it's just like anything else, like a broken leg or, irregular periods, anything like that. We treat it like an actual diagnosis that we need to manage as best we can and get you through that phase. A lot of patients don't want to get on antidepressants, and that's also fine. And so for those patients, I usually will go through kind of our cognitive behavioral therapy options, which basically is just talking to a therapist, and making sure you have a good support group, people within your family, your friends, even your provider who can kind of provide support for you during that time and kind of let you know, hey, you're not crazy. This is totally normal. This is part of this menopausal transition. And if we get to a point where just doing kind of things like acupuncture and therapy and massage and all these things doesn't necessarily work, then maybe we should be talking about getting you on an antidepressant or on something. But it's definitely something that people don't necessarily obviously think of when they think of menopause. They're thinking hot flashes, they're thinking vaginal dryness, they're thinking those things, but mental health is a very big part of it.
One of the other things that somebody brought up is, when should a hysterectomy be recommended? And I'm guessing this is such a bigger discussion because it's not just a hysterectomy related to menopause,
Right.
because you wouldn't have a hysterectomy just because of menopause, right?
Right. Yes.
That's
So
not how we're fixing this.
exactly. So, I mean, if you go back to, the 1940s or 50s, they probably were doing that, but these days it's not recommended.
Yes.
Just because a hysterectomy is a big surgery. I mean,
Yeah.
we're still going into the abdomen, we're still making incisions, we're still removing an organ that has provided a function throughout your life. And so typically hysterectomies we would only do for a specific type of pathology. And by that, I mean something like endometriosis, something like fibroids, anything where something is actually wrong in terms of the uterus that is really affecting your life, then we would talk about a hysterectomy. But just for menopause, we typically don't. And especially because it wouldn't really fix menopause, because the menopause is associated more so to the ovaries. And so removing the uterus would only change the actual bleeding pattern people are having, but it wouldn't change your actual symptoms, other symptoms.
Yeah, taking out your ovaries, that means we get rid of all of it anyway, right?
Exactly.
We've got no estrogen happening.
Exactly.
Got it. One of the other questions that people asked, was there a way to check your egg count? And I don't know if that means like check it from back in the day, so we can kind of count out and be like, okay, how long am I going to have to wait till menopause? Or, I mean, we can't count eggs unless I guess you on some level through an ultrasound, you could probably do that, right?
Yeah. So with the ultrasounds, what we can do is get what we call an antral follicle count, which is basically at a specific time in your cycle, we're able to see the actual follicles that the eggs are, or the ovaries are growing. And so there's a normal number or range for that. And so we'll see as people get older, the antral follicle count will go down. That's not a specific count in terms of how many eggs you have left. It just tells us how many are there for that cycle. But since we have an idea of what is normal, we can say, okay, this antral follicle count is a little bit lower. So it might mean that we're getting closer to menopause. And there is blood work. There's a hormone called AMH, or anti-Mullerian hormone, which is associated with your egg reserve. And again, it doesn't give us the exact number of eggs that people have, but it does give us a sense of what your egg reserve might look like. And so if it's on the lower end, we know, again, okay, we might be getting closer to menopause. It doesn't help us in terms of, well, how long exactly do I have until menopause? So we can get this number and say, okay, based on this, it looks like your numbers are normal. You've still got a little bit of time until menopause, but we can't say, okay, you're going to go through menopause in 5 years or 2 years or whatever it might be.
Yeah. It's interesting because when you rattle off all the acronyms, I'm like, oh yeah, like anytime you've gone through fertility treatments, reproductive health kind of stuff, like you learn all these things. I never thought of them in terms of what that means for when menopause might start for you.
Yep. And I mean, all of these are a little bit intertwined. And so the AMH, for example, is used a lot for fertility. So for people who are checking prior to pregnancy or trying to kind of make sure that everything's okay, that's the same number. And that's just because the egg count is related to your fertility and it's related to menopause as well.
Yeah. So I feel like our conversation today has been so easy. Again, I feel pretty comfortable talking about these things. This is something I talk about with my girlfriends. And clearly you are the person people want to talk to about all of this. Not everybody's got a Dr. Mbe in their life though. So what would be your advice for how do people start this conversation, whether it's with their physician, with their mom? Like I can even imagine some folks are going to have a hard time asking their mom about this kind of stuff. How do you begin that conversation?
It's definitely a harder conversation to have. And especially given the stigma around it. I think even for myself, when I was talking to my own mom about it, she was like, we don't talk about that. And so I was just like,
Mom, I'm a doctor, you know that, right?
Exactly. I was like, I talk about this all the time. So with her, it was just kind of one of those things where I was just like, okay, but why don't you want to talk about it? And so we had to kind of unpack that a little bit. But we eventually had our conversation. With your provider, it's a little bit different because they're the expert. They should be kind of the ones asking you about that. But if you're having certain symptoms and you're like, okay, this seems like it feels like I might be starting the menopause journey, and I really want to ask you about, what can I expect? I just want to be prepared. Like, what treatment options might I have? Any provider that's an OBGYN that takes care of menopause all the time is going to be more than happy to talk to you about those things, because that's just part of what we were trained to do.
Yeah.
And menopause is something that you shouldn't have to struggle through. With friends, I think it's maybe a little bit easier because everyone hopefully is kind of aware and maybe thinking about these things already. And a lot of times it just takes one person in the friend group to just bring it up for everybody else to be like, oh, wait, I'm having this issue too. Or like, I heard from my mom that she went through that as well. And just being able to provide that space that's supportive, that you're comfortable with, to talk about it is really important, just because I think knowledge is power, knowledge is safety, and that the more you know, the more prepared you are, and the less you're going to be shocked or kind of thrown off by anything that kind of comes your way.
Yeah, I mean, that's completely true. I mean, that's kind of the whole point of why the Women's Fund exists in so many ways. And so talks like this are the hope that, everybody does hear this and then we pass it on. That's the goal.
Exactly.
There's however many of us here today, we all take this knowledge and just start talking about it with each other.
Exactly.
Are there any new developments when it
Mhm.
comes to menopause? What's out there next? I mean, we kind of ran through the basic protocol for today. Are there things that you're seeing either from a research standpoint or things that other physicians are trying that you
Mhm.
think might be like the future?
Yeah.
Or do we
I
even need a
think,
future? Are we good? Like, is this
yeah.
good?
I mean, I always think we need more in women's health in general. So there is research going on in terms of, predicting menopause a little bit better. So people are looking at a specific subtype of AMH that might help us be able to tell people, okay, it looks like you're going to go through menopause in a year, or you're going to go through menopause in 5 years. And I think that's going to be great for people who are especially concerned about symptoms, or especially concerned about maybe trying to get pregnant later in
Yeah.
life. So that's research that's happening right now. There is research going into kind of other ways to treat symptoms of menopause, especially non-hormonal options, because again, we want to be able to provide care to everybody. And there are some people who just are too high risk for us to offer hormone replacement therapy, but they're still having significant symptoms. And so how do we treat them when, the antidepressants don't work or the acupuncture doesn't work? So there is research into other medications, other supplements that might help people, and that make it easier for people to access something over the counter to help with their symptoms too.
Yeah. So I can tell how passionate you are about this. I know we've talked a lot about the topic. I'd love to hear more about how you got into this.
Yeah.
Like, how did this become like your thing?
Yeah. So I love OBGYN care in general, just because I think women are great patients. Women and people with uteruses in general are great patients. And I think that it's one of the areas that's been overlooked for too long. And I obviously am identify as a woman as well and have to go through all of these things. And I think it's even just seeing my own mother going through menopause and struggling with it because she didn't have a doctor she felt comfortable talking to. And knowing that there are lots of other people who are going through that same thing and not feeling supported by the person who is supposed to be helping them the most. And especially when it's been several decades, years that people are just kind of trying to shuffle this under the rug, when it's something that is normal and beautiful and is just a normal part of life. We kind of need to embrace it, but to embrace it, we have to talk about it. So it's just like anything else in women's health. I think the more we talk about it, the more people will be comfortable with it, and the more research we'll get into it to better treat people who are going through these things.
Yeah, I love that. I mean, because it's honestly the reason I love talking about these things. I hope that, whatever the topic is, if there's something we can do as women to help the next person, not to struggle so much with it. And you're right, a big part of that is talking about it and having knowledge. I mean, if you actually have some knowledge behind that, it's not just talking.
Yep.
You really can come up with some action steps. And you're right. Part of that key is finding a good provider. What do you
Mhm.
what advice would you have for people who maybe have a provider that is less than receptive to dealing with their symptoms? Maybe somebody who's like, oh, it's just part of life. Yep, hot flashes. I've been through it too. Yep, yep. Your mom went through it. You'll be all right. What do you say? Because I know that is happening to people.
Yeah, yeah. So one of the things I will usually tell people is make sure you have kind of your symptoms or questions written down before you go to your appointment with that person. Because usually it's a little bit anxiety inducing to go to the doctor's office. Even I get a little bit of doctor anxiety going to the doctor. And so I think it helps to have it written down so that in that moment, you're not forgetting anything. And especially when you're able to kind of come to the doctor and be like, okay, I'm having these symptoms this often, they're this bad. So I really want to talk to you about how I can treat this. Like, that is my goal for this visit. That makes it clear to the provider, this is really important to this patient. You can also now bring somebody into the office with you as kind of a support person, as kind of a second voice to kind of help you. So for example, with my own mom, I went with her to her appointment to kind of be like, no, you're not taking this seriously enough. She is having really significant symptoms, and I need you to address it as, as seriously as it is. That could be just your friend, that could be, a family member, but just having that second person there a lot of times just provides like an extra bit of a push to kind of get that provider to, take you seriously. And then sometimes you really do have to leave that provider and go get a second opinion or see somebody else. And especially if you've tried these things and they're still kind of not receptive to it. And especially if they're not really explaining why they're not really receptive to it, then I would probably, that's a red flag for me. I would recommend maybe talking to somebody else about it then.
Well, and I loved hearing in the beginning of the conversation for people maybe who joined us late, now that we have these virtual options, in our healthcare, and it's available in this space as well. And it sounds like that's a good choice or could be a good choice, or at least an option for some people, especially people who don't have high risk factors.
Exactly. Yeah. And so that's definitely one of the reasons I'm excited about it. I think it'll make it easier both for people trying to get a second opinion, and just for people who are still, maybe shopping around for a provider or trying to find a provider that they trust and feel comfortable with. So being able to have somebody available to you just on your computer, on your phone, is going to make it easier for a lot of people to be able to get the care that they need.
Yeah. Well, Dr. Mira-Mbe, thank you so much for being with us today. This was awesome. Like, I mean, I feel like I need you like in my pocket,
It's my pleasure. I love doing this.
This was really great. I'm now going to thank you all for joining us. I'm going to turn it over to Jennifer with the Women's Fund.
Hi, everyone. Thank you, Dr. Mbe, for such an informative discussion. We appreciate your expertise on this topic as we now leave you with wonderful information about our hormones and our menopause. We understand that you took the time from your busy workday to provide this valuable information with our community. And for that, we are very grateful. For everyone online, hi, my name is Jennifer Ramirez, and I am the program coordinator for the Women's Fund. And we are thrilled that you were able to join us on this Thursday afternoon for another great discussion. I would like to take this opportunity to thank Casey Curry for taking part in today's crucial conversation, and a huge shout out to the Alliant Group for hosting us today, and Casey for helping us coordinate it all. Additionally, we could have not done this without our doc series sponsors, the John P. McGovern Foundation and the Wendy Haskell-Meyer Endowment. Their support for close to 35 years has been instrumental in the Women's Fund success, and their help has provided funding for today's programming. Thank you for attending our last Doc Talk of the year. If you have an interest in a certain topic for future Doc Talk events, please reach out to us through our website or drop suggestions in the chat. If you enjoyed today's program, like us on Facebook to stay current on future events like this one. To see complete list of topics and dates, visit our events page on our website at thewomensfund.org to register. And again, please follow us on Twitter, Instagram, YouTube, and Facebook for more updates on this information. And so to conclude today's Doc Talk, I just want to say thank you all for joining and enjoy the rest of your day. And please stay safe and healthy.